In this lecture, we're going to be looking at Jeff Maitland's approach to the management of low back pain and patients with lumbar disorders. Hopefully you've printed off your slides for today's lecture, and so as we begin to work our way through the lecture, then please follow along in the slides, make notes, make any questions that you have, please jot them down, and you'll be able to email them to me, and we'll get back to you as quickly as we can. If, however, you're just viewing this a few days before the lab sessions, then please just make a note of your questions, bring them with you for our Saturday lab, and we will certainly spend time and answer those and talk through those questions. So, during this talk, what we really want to do is we want to begin to understand the contribution that Jeff Maitland gave to the whole arena of manual therapy, in particular the realm of low back pain care. A couple of definitions that Maitland uses that are kind of important to really understand is that if we want to try and follow his concepts, we've got to get in touch with his terminology. And to follow his terminology, then we really need to understand what he says, what he's describing, and this may be a little different from how we've used the words in our own practices before. So we've got to be careful of that. So I want you just to not identify the words with what you've previously learned them as, but maybe consider these words in a fresh light today and in a new way. The first word that we just want to identify is signs. In Maitland's terminology, he defines a sign as any finding in a joint or structure which is abnormal. And so that's what we're going to consider. When we talk about signs and symptoms, we're going to be talking about signs being any finding in a joint which is abnormal. Symptoms, as Maitland puts it, is something which the patient complains about. Not something that you objectively measure, but something that the patient then comes in and says, this is what I'm experiencing. This is what I'm feeling. And so we're going to use signs as those abnormal findings that we can identify, and then we're going to use symptoms as those findings that the patients then bring to us. Clear is the third definition, or the third word that we want to define according to Maitland's notation. And basically clear means without any signs. Different from without any symptoms, because the patient may describe a structure as being painful, but whenever we go to clinically measure it, we can't reproduce that pain. We can't identify the signs that they're mentioning in terms of symptoms, and so that structure or that joint is considered to be clear. No signs basically means that there's pain-free motion, full range, plus with the addition of overpressure, so we can overstretch the joint just a little bit, and that still doesn't reproduce any of the patient's complaint. Further definitions that we need to consider: active physiological movements. An active physiological movement is a movement that is performed by the patient. That's a movement that is under their control. It's a movement that they can accomplish, and we just need to instruct them in that. And then passive physiological movements are those same motions, however, they're performed passively, so they're performed by us as the therapist. And these definitions will come into play as we get into our practical sessions and we start to actually put our patients into certain positions. We want to really be able to actively and passively position our patients so that we can get the best effect out of our manual techniques. Final definition that we have then is our passive accessory movement. And in passive accessory movements, we are describing motions that we perform on the patient, but they're accessory motions. When every joint moves, it has its physiological range. So we always consider flexion, extension, abduction, adduction. But they're also, for those physiological motions to take place, there has to be some degree of accessory motion that takes place as well. And those accessory motions are that slide, glide, and spin theory. Remember way back whenever we first learned about the movement of joints, and we considered the shoulder joint, and how as the shoulder joint moved into flexion, then there had to be a level of spin of the humeral head. There had to be a level of slide of the humeral head to maintain the joint congruity and maintain the joint integrity. And so those slide and spin and rolling motions are the accessory motions. If the accessory motions are absent, then physiological motion is not going to be complete. So if we've got patients that are struggling to maintain or achieve full range of motion, then we need to identify is there some level of loss of accessory motion, which is what's causing them to not be able to physiological move to the full range of their motion. So these passive accessory movements are movements available within the joint that are performed passively by the therapist, but the patient themselves cannot actively perform them. So if you go back to the shoulder and you consider the shoulder joint, and we talk about this spin. Well, the spin occurs during the physiological motion, but we can't ask the patient to spin their humeral head. It just doesn't work. Try it now as you're sitting there. Try to just glide your humeral head. It doesn't work. But that accessory motion has to be present for normal physiological motion to continue. So moving into Jeff Maitland's ideas and concepts when it comes to the management of low back pain. One thing about Maitland is that he really emphasizes clinical decision making. And a clinical decision making process, he defines this as an assessment oriented, it's assessment oriented following meticulous acquiring of data. In Maitland's whole philosophy, what he is looking for is that we evaluate our patients, we obtain data, we obtain information from our assessment, from those evaluations, and then we take that data, we process that data through our understanding, through our experience, through our knowledge of what the evidence says and what the research has said. And then we come out with findings that suggest to us or direct us in the most appropriate way to treat those patients. And so we need to consider assessment, data acquisition, processing, then the application of techniques, and then reassessment. We never really know if anything has worked unless we reassess it again. And in Maitland's philosophy, we'll spend a lot of time assessing, treating, reassessing, assessing, treating, reassessing. And I know that for some folks, this may be a bit of a weird or a strange idea to stop your treatment to reassess. But by doing this, we're ensuring that we're being effective. And we're also ensuring that if we're not being effective, we can change quickly so that we can become effective in our treatment. So Maitland describes this clinical decision-making process. It's assessment-oriented, following meticulous acquiring of data from the patient's subjective examination and the physical therapist's objective assessment. So in our other two lectures that are a part of this module, we deal with the subjective evaluation and we deal with the objective assessment. And so you can look at those two after you've viewed this lecture. And then we will cover some of that material whenever we come back together in our lab session. As I said, Maitland is also concerned with the development of hypotheses. And before you have that little freak out about memories from your research days as a physical therapy student and your hypothesis forming and all of those things, what Maitland describes as the hypothesis is that what he's saying is that we don't go into our patients blindly. We don't go into our evaluation and our assessment blindly. We are constantly acquiring information and we're coming up with, okay, what is that pattern? What is that potential physiological problem? What is the anatomical location that is damaged? We're constantly assessing and evaluating and plugging that information into what do we think it is? At the most basic, our hypothesis is our gut feeling on what we think this condition is. And sometimes you get that early in the process. You've been there, you've had patients where you're listening to their story, you've heard the same story a number of times, and you just think this is what this probably is. As you go through your objective assessment, your evaluation process, you begin to confirm that hypothesis. Or you begin to query and question that hypothesis. Something doesn't quite fit. As you're testing a structure, you're beginning to think, well, this should be what's pain-provoking. However, it's not. And so something is just not quite right there. And so with our hypothesis forming, we come in, we hear our patient's story, we question them, we gain information through our subjective, and we begin to formulate an idea. We begin to formulate a thought as to what the problem is. Then as we check our objective and we evaluate our objective tests and measures, then we begin to affirm our hypothesis, or we might need to change it. With Maitland's approach, primarily, but not exclusively, his treatment incorporates accessory motions and accessory mobilizations. I know that a lot of people just think that that's all that Maitland does. There's these misconceptions about our manual therapists and the philosophies of manual therapy where they just get pigeonholed, and that all that Maitland does is he just does those mobilization things and manipulations. All that Cyriax does is just manipulation. All that Mackenzie does is just back extensions. Well, Maitland's not quite that rigid. Neither are the other two philosophies for that matter. But what he's looking at is primarily, we're looking at the use of accessory mobilizations, restoration of those accessory motions I discussed earlier to restore normal physiological motion. And so that's what we're going to look at. Things that Maitland has really contributed to the literature and to the body of knowledge in this whole arena is the grading of these mobilizations. Not just the idea of trying to restore, but how do we restore them? The idea in this concept of identifying barriers, and then in the process of identifying the barriers, being able to treat up to a barrier or beyond a barrier. And so as we look at it, and particularly when we get into the practical sessions, you'll really begin to see, we start to identify barriers, start to feel for barriers. And Maitland brought that in with this idea of these graded joint mobilizations. And what we'll be looking at in our lab session is mobilizations that are 1 through 4. Maitland has 5 mobilization levels that he uses. 1 through 4 are within the normal physiological range. His grade 5s are would more be considered manipulations that are just outside of the patient's control. Those short, sharp thrusts just towards the end of range, just to help encourage that joint or those structures just to regain the motion that they've lost. What we're going to consider is that in terms of we're going to use mobilizations, then we are dealing with hypomobile joints. There is no point in mobilizing an already mobile joint. There is no point in going into a joint and really trying to regain range if there's no loss of range. And so as we are working with our patients, we're going to be dealing primarily with hypomobile joints and not hypermobile joints. His principles of treatment, really there has to be an understanding of biomechanics. It would be really useful for you as you come to this course, and particularly our lab sessions, if you just have a quick review of the anatomy and the biomechanics of the lumbar spine. Just to make sure that you're up to speed, that you know where the facet joints lie, you know the angles of the facet joints, you know as the spine moves into flexion, the direction that the facet joints move, you know how the facet joints move during rotation, during side flexion, what happens on one side compared to the other side. Because we have to have that biomechanical knowledge and that understanding of where structures are and what structures do. However, that knowledge does not dictate the treatment that we use. And for some people, this is a little confusing issue when it comes to Maitland's philosophy, because he's not bound by, if it's a flexion issue, you have to do this. But he has established an order of efficacy for his mobilization techniques that we'll cover on Saturday. But what we've got to look at is that he has, over the years, through research and through evidence, has shown that certain techniques are more effective when the pain is unilateral or when the pain is bilateral. When the pain is central, then there are certain techniques that we will utilize in those instances. And so when it comes to the understanding and the evaluation of what's actually going on with our patients, then that background knowledge is essential. When it comes to the treatment, then following his concepts and following his order of efficacy is the way that we're going to move forward. His key principles then, clinical assessment. And we're going to run over these one by one. But clinical assessment is one of his key principles. A mode of thinking, developing a thought process. And for those of you who are new to this idea, new to this philosophy, this may be the most difficult thing for you. We are teaching you a way of thinking and a way of practicing, and not just a series of techniques. If it were just a series of techniques, then you could probably pick those up fairly easily and then try and apply them. But it's in the understanding of why we apply them that then you're going to get the best benefits. And so it's a way of thinking that we're going to try and teach you. We're going to discuss irritability and the nature of the condition. And Maitland has a couple of interesting thoughts on irritability that we'll come to. We're going to look a little bit at pathology, look at the role of diagnosis and diagnostic tests and procedures. For some of us, those are the things that we hold on dearly to, that we can't treat unless we have a diagnosis. Well, that's not always the case with Maitland's way of thinking. And then we're going to think about treatment of pain, pain-dominant disorders, and also stiffness-dominant disorders. Just a few simple things to remember as we move forward. I said at the start that Maitland's approach is about evaluation, treatment, reevaluation. And so we're going to keep this idea in our head that we're going to collect data through our examinations, through our assessments. We're going to interpret the data. So we're going to take what we find, we're going to interpret it to make sense of it, to combine it together, to put it together, to come up with a treatment plan. We're going to then take that treatment plan and we're going to carry out that treatment plan and do the techniques that are appropriate. We're going to treat our patient in the way that our assessment and our evaluation have directed us to. And then we're going to reassess to see if it's working. Now, that may sound a little bit confusing because, well, surely don't we have to treat for 2 or 3 weeks before we see results? Not necessarily. Some of the techniques that we will show you and some of the treatments that you will do on your patients, hopefully, will be immediate in their effect. Now, not always will they be immediate with a positive effect. They may be immediate with a negative effect, but a negative effect is a positive effect. Let me explain that. In a situation where you have taken your patient, you've evaluated their patient, you have taken in all the information, and now you're beginning to apply a level of treatment. And you decide that it's an L3 issue. And so you begin to palpate and you begin to mobilize L3. And their symptoms suddenly increase. Well, their symptoms increase because of something you did, which means you had an immediate effect. Now, if you had an immediate detrimental effect, it means that condition is responsive. So that condition being responsive and you had a detrimental effect, now, what can we do so that you can have a beneficial effect? How can we change it over so that the next time that you go into treat or the next technique that you select actually produces the results that you require? And so negative effects are actually positive effects if we look at them in that light. So let's look at the clinical examination. Clinical examination is described by Maitland as an unremitting process. An unremitting process where the patient is the most valuable source of information. Now, sometimes we forget that. We forget that we're working in partnership with our patients. And we need to understand that our patients they have all the answers. All of the clues that we need to understand what's going on with their problem, they have them already. And so we have to look at our patients as that source of information that we're going to mine, that we're going to question, that we're going to quiz, we're going to evaluate so that we can get every nugget that we need. We want to focus our examinations to daily examinations, not just twice a week, 3 times a week, whenever you bring the patient in, but a daily examination schedule. Now, I know that we're not going to see our patients every day, but we need to identify in our patients a test or a movement that they can do which reproduces their signs, which they then understand, but then also what that tells us is whether they're getting better or getting worse. So when they come into the clinic and they perform forward flexion, and they bend forward and they only get down to just above their knee, and their back pain comes on, well, that becomes our daily test. So each day when they're in the clinic and each day when they're at home, we want our patients to do that forward flexion test to see, do they get a little further before the pain comes on? Is the pain the same intensity when it begins? So they still get to their knees, but it doesn't hurt quite as much. So every day there's a little bit of evaluation, because every day we're looking for some sort of improvement or some sort of change. Our examination is going to be analytical. We're going to analyze the data that we get. We're not just going to get answers to questions and fill in checkoff sheets and not actually think and process that information. The analysis of what the patient gives us will steer us completely in the right direction. That lack of analysis means that we haven't focused our thought. We haven't begun to clinically reason our way through the case. We're just basically filling in boxes on a sheet. And we want to be differential. We want to be differential in our examination in that we want to think, okay, is it this structure or is it this structure? Is there a test that we can do which will provoke these symptoms, but if that's negative, then does it provoke these symptoms? When we consider the low back, the common differentiation that we need to make is between, is it a discogenic condition or an arthrogenic condition? So are we dealing with a disc or a joint? And so as we go through this process, we're going to be looking at being analytical, but being differential. Our clinical examination also focuses on the behavior of the patient's comparable sign and the patient's symptoms. The comparable sign is that sign that is what the patient complains of. As I said, when we do the forward flexion test, the patient bends forward, and their back pain comes on. Is that their back pain? Is that the pain that brought them to see us? Or is it something different? Because a lot of times we just ask, well, does that hurt? Tell me when it begins to hurt. And we move our patients and they say, that's sore and that's sore. But if it's not their pain, if it's not the pain that brought them into the clinic, then it's not their comparable sign. And so with our comparable signs, we're going to identify a motion or a test which brings on or elicits their signs and their symptoms. And the final thing about the examination is that it follows an organized format. When you go through the lecture on the objective examination, then you'll see this systemized format of always starting at the same place and working your way through each of the structures to be able to come out at the end with a differential diagnosis, with the ability to say that it's this type of condition, it's arthrogenic, it's discogenic, it's at this particular level. And so that's what our clinical examination aims to give us at the end of that time. I talked about hypothesis. During our clinical assessment, we are going to be generating hypotheses. We're going to generate an idea as to what we think it is. It's going to go from a gut feeling into a stronger idea of, yep, this is what I think this problem is, to a full-blown hypothesis, to a reinforced hypothesis, where we have information from our objective examination that reinforces and reaffirms that hypothesis. Or we might need to modify it here and there. I want to encourage you, as you step into this realm and into this philosophy, that you begin to think laterally. A lot of times we become very linear thinkers, where we're looking for cause and effect and cause and effect and cause and effect all the time. And we don't allow ourselves to think a little bit wider. But by having that ability to think laterally, then it helps us to gain more information. That information that doesn't fit our linear tracks, which would confirm our hypothesis, we ignore. But when we start to think laterally, then we open up our antenna and we begin to absorb some of those other pieces of information, and that really then helps us to clarify what the problem is. So I want to encourage you to think laterally. That may not be you. That may not be how you think, but let's just try it. Let's try and just think a little bit outside the box. Let's just make sure that we pull in all of the information that the patient is presenting to us. Remember, they're our biggest source of information. So let's not let any little thing go by. Let's take it all in and then slot it all into its appropriate place. So I said earlier that our clinical evaluation is going to be daily, it's going to be analytical, and it's going to be differential. Those are the key words to keep in your mind. Daily, analytical, differential. When it comes to the comparable sign, I've got a little slide there, I already talked about this, but we talked about our joint signs being those abnormal signs or abnormal motions that may be observed or felt, either through stiffness or spasm, instability, again, a joint sign. But that comparable sign is that sign which reproduces the patient's symptoms. And we're going to talk about that continually. The comparable sign, the comparable sign. Is that your symptoms, or is that your problem? We're going to keep going back to that. So hold those two thoughts in your head. Hypothesis generation, which we've discussed quite a lot. In our hypothesis generation, we've got to consider a number of factors. The site of the disorder, the joint or the disc, the location, upper lumbar, lower lumbar, depending upon the signs and symptoms that may or may not be present in the leg. That helps you with your hypothesis in terms of understanding your dermatomes, myotomes. We'll come to that later on. The mechanism of the injury in the first instance. What actually happened? What did the patient do to get themselves into this position? But then also the mechanism in terms of the location. Are we dealing with a central problem, where it's really the central nervous system or the spinal cord, maybe upper motor neuron disease, something like that, a little bit more serious of a problem, a bit more sinister? Are we dealing with a segmental issue, which is more localized at, say, an L2, L3 or an L3, L4? Or are we dealing with a peripheral problem, where the issue, the patient may be experiencing pain in the low back or down along a nerve root, but it's the nerve root that is the cause. It's the root cause of what's going on. And so we've got to understand those. We've got to understand any prior treatment. We've got to ask about that. Have you had any treatment before? Was it effective? Was it not effective? If it was effective, why are they still not doing it? If it wasn't effective, then what did they do? Because if it didn't work before, it's probably not going to work again. And so we need to be mindful of that. We want to think about and consider a prognosis. Are there any particular indicators that would really point us to a particular prognosis for this patient? We want to consider precautions and contraindications. And then finally, we want to think about any other predisposing factors. Any overuse, any disuse, any postural issues. When we have patients who come in who've got low back pain, but they have not been able to take a break, they've not been able to rest from the activity that caused the low back pain due to some sort of socioeconomic reason, then that's a predisposing factor. We can treat that patient and try and get symptomatic relief in the clinic, but we know that they're going to go back to work, and when they're at work, they're going to just re-injure themselves. And so we've got to consider that as part of our hypothesis generation. At the end of the day, we want to keep it simple. We don't want to get too fancy, too involved. We want to keep it simple. Because as we keep it simple, then it helps us with clarity. When we start to get too involved, then we lose our focus, we lose our clarity, and we're not really sure where to go with our treatment. Because we have all of these details, we don't know which one to hit first. We want to just state the problem. We want to prove that it's the problem. And then we want to do something about it. We want to actually fix the problem and address the issue. When it comes to our mode of thinking, I said earlier we need to have that good level of biomedical knowledge, our anatomy, our physiology, pathology, biomechanics. What is known, what is believed. Those are often two different things. Something that is known and has been proven to something that is believed and is as of yet untested. So where are we with those issues? What may remain to be proven or is currently being questioned? As you read literature, as you read journal articles, a lot of times there'll be new concepts that'll be thrown up. And some new concepts you'll try. You'll try them in the clinic. Well, I read this and it said that it was effective, so let's try it. But it's an unproven concept. It's just a theory at this point. And you may have had some great success. So as far as you're concerned, it works. But it's still unproven. And so as we come into our mode of thinking, we're going to be considering what's known, what's still being tested, what's just a theory. We're also going to consider the clinical presentation that the patient presents with. We want to look at their history. And we address this in our subjective examination talk. We want to look at the signs that they present with. We want to look at the symptoms that they present with. Above everything else, we're focused on the patient. Don't focus on the condition, but focus on the patient. I said we have to keep that lateral thinking because sometimes we miss some of the psychological or the sociological issues that our patients are facing because we're linearly thinking about the lumbar spine. So let's keep that open mind. Keep the patient as our focus. We're constantly going to be processing what we hear, what we see, and what we feel. And in all that, we're going to reason our way clinically through the condition and through the presenting signs and symptoms. This is what Maitland's philosophy is all about obtaining information, analyzing it, evaluating it, and then using it to identify a treatment and then giving that treatment. Now, I said earlier I wanted to talk a little bit about irritability and the nature of the disorder. Irritability is basically how much activity or how much of a movement needs to be done and how that affects symptoms. If we perform just a small amount of motion and that increases symptoms to a great extent, then we might consider that patient to be irritable. If it also then takes those symptoms that we've now elevated a long period of time to settle or return back to their resting level, then we would definitely consider that patient to be irritable. The problem with irritability comes in when we start to try and grade irritability. And you may do this, and this is not to offend anyone or not to go against anybody's thinking, but wouldn't it be so much easier if we could just classify our patients as being irritable or not irritable? Now, I know that that's, just two classifications. It's only two divisions. You are or you're not. But by doing that, it actually will help us as we approach the treatment process of our patients. So if we look at our patients with, in terms of irritability, in terms of are they irritable, well, how much motion, how much activity caused how much of an increase in symptoms, and how long did it take to settle? Well, if we can determine, yes, they're an irritable person, then we're going to be very careful. When it comes to the application of our techniques, we're going to be mindful that they're an irritable patient, that they've got an irritable condition, and that we're going to then be a little bit more cautious with the grades that we use, with the aggressiveness of our treatment. But if we've classified them as being non-irritable, then we're going to be able to go in there and mobilize. We know that by doing certain activities, we're going to cause an increase in symptoms. But we also know that that increase in symptoms, that elevation of their pain, is going to decrease relatively quickly. So it's only a temporal thing. And so if we've understood that and if we've accepted that, then we might be a little bit more aggressive. We might try and push that patient a little further. And if we push that patient a little further, then are we going to get the results that we really want to see? Sometimes when we misclassify our patients and we take those irritable patients and we push them too hard, we actually set their symptoms off so much that they may be in pain for 2 or 3 days. And no patient wants to come to clinic and then for us to do something which then causes their symptoms to become unbearable for the next 2 or 3 days. We lose trust. They lose faith in us. And so let's classify and consider classifying our irritability by, yes, it's an irritable condition, or no, it's not. When it comes to the nature of the disorder, then we've got to consider, is it a mechanical issue? Is it some sort of joint, discogenic? Is it a mechanical problem? Is it an inflammatory problem where there has been some sort of insult or injury, but then the inflammatory response that the body has set up is now what's causing the most of their complaint? Or is it something that's more sinister? Something that's more serious, that's going to involve further testing and further investigation by doctors other than us. We've got to consider those three things when it comes to nature. Now, as I said, this idea of irritability. The irritable disorders are characterized by constant or severe intermittent pain. They're characterized by that pain being easily provoked and it taking a long time to settle. So if we were looking for some examples, then consider whiplash. Some of the stages of whiplash, particularly those earlier stages where there's been a trauma, and then as the patient begins to move their head and neck, then their pain level just shoots through the roof. And it takes a long period of time for that to settle. That's what I mean by an irritable disorder. It could be severe trauma, it could be active nerve irritation, stuff like that. When it comes to the irritable disorder and rest is vitally important. Positions of ease are vitally important. Because if we know that small amounts of motion cause this patient's symptoms to go through the roof, then we've got to figure out, okay, well, what positions can they stay in or remain in or do their job in or function in that's not going to cause all of the problems. And so we've got to consider positions of ease. The appropriate motions and the movements that we get these patients to do with these irritable disorders will actually be pain relieving and not pain provoking. And so we've got to identify those. We want to decrease the chance of accelerating or increasing, intensifying that inflammatory response. And so with our irritable patients, we want to be very, very careful. This is a critical factor to consider. Because if we don't address irritability, then we haven't really heard our patient. If we haven't picked up on how their symptoms are affecting their lifestyle, then we haven't heard our patient. And so this is one thing that is critical that we have to keep focused on. When we have determined our level of irritability, we've said yes, they're irritable or no, they're not. Well, that directs our treatment. And there's a slide there which talks about this. On one side, you've got an irritable patient or an irritable condition. On the other side, you've got a non-irritable condition. On the irritable side, then we're looking at using grade 1s and 2s. Okay, Maitland's philosophy, pain relieving, gentle motions. We're going to do very, very brief bouts. We're not going to do prolonged periods of these mobilizations, but just very quick, 20 seconds, 30 seconds. We're going to do very few bouts. We're not going to keep on going and keep on going. We're going to be mindful of the condition. We're going to be mindful that this is an irritable condition. We're going to always stay short of barriers. And I'll talk about barriers later on. We're going to try and find a position of comfort. And we're going to stay in the early part of the range of motion. Now, on the non-irritable side, we're completely different. We're going to use grades 3s and 4s, possibly grade 5s. We're going to spend longer amounts of time actually performing the mobilizations. We're going to maybe do more bouts of mobilizations because we can do more. The patient isn't going to respond in that negative way. We're going to work into barriers. We're going to identify where the resistance is, and we're going to push into it. We're going to push into those pain levels. We're not going to be limited to work just at the beginning of the range. We're going to work all the way to the end of range. When it comes to pathology, continuing on our list of things to consider in Maitland's philosophy. When it comes to pathology, we have to understand the pathophysiological responses of the structures in the lumbar spine and in that region and how they respond to injury. We have to understand the stage of certain diseases. We have to understand the timeline of those diseases. We have to figure out, okay, if this is the condition, well, what's the normal healing process? How do we accommodate that? How do we fit that into our treatment? How does that play into the signs and symptoms that the patient is presenting? We have to take that information. We've got to consider the mechanism of injury. We've got to consider, well, this is the patient's story, and so here is anatomically what may well have happened. A lot of times when we get that information from the patient, we get some information that might direct us towards particular tissues. But don't be linear. Don't be narrow-minded. Keep your mind broad. So that, okay, I hear that. I hear that it's pointing towards a particular type of tissue. But let's not just exclude everything else. Let's identify that as the most likely cause, but we haven't ruled everything else out yet. So let's keep it and hold it in tension in our minds. We have to consider the multifactorial nature of pathology, the way that pathologies can affect other structures, the way that inflammation at a joint can not just affect the joint, but it can also affect everything that's in close proximity to it, like nerve roots. And so whilst the patient is presenting with nerve root pain, it's because the joint is inflamed. If we treat the nerve root pain and don't address the joint, then we haven't addressed the problem. But if we address the joint and we treat the joint and the inflammation subsides, then the nerve root problem should disappear. We don't want to get stuck in a diagnostics trap where we just become so focused on the tissues. Well, this is tight, and that's tight, and this is tight. We've got to understand what's the cause. What's the root cause, which is triggering these other structures to develop these abnormal signs. We want to continue, as we consider pathology, using our clinical reasoning skills to make sure that our understanding of the pathology and what's being described to us fits our hypothesis. And if it doesn't fit, then it helps us modify our hypothesis. Most of the patients that we get, they're not just single pathology. Oh, if they only were, it would make our life a lot easier. But they're often multifactorial. And so we've got to weigh all of those things in mind. We've got to keep in tension the primary location, but then all the other secondary locations that are also affected because of the primary insult. When it comes to diagnosis and diagnostic tests, we want to respect the diagnosis, but to be honest, a diagnosis is very little value to you at all. When your patient walks in and the diagnosis is low back pain, what does that really tell you? Well, how does that help? Well, it just tells you that they've got pain in their low back. That's it. That's all that really gives you. It doesn't tell you where. It doesn't tell you why. It doesn't tell you how. It doesn't tell you what type. But yet we cling to that diagnosis. Oh, they've got low back pain. Well, that's not specific enough. That doesn't really help us to get in and treat the root cause. And so whilst it's valuable, let's not cling too tightly to it. Let's maybe develop it. Let's maybe deepen it a little bit and identify the precise structures. So our low back pain becomes a discogenic problem between L3 and L4. A posterolateral bulge of the disc between L3 and L4. Compressing the nerve root, causing pain radiating down across the buttock into the anterior thigh. That's a diagnosis that we can actually work with because it tells us the precise location, it tells us the nature of the condition, tells us the extent of the condition, and it gives us an idea as to where to begin. And so don't get so wrapped up tightly with the diagnosis. Diagnostic tests. Again, we sometimes get so wrapped up with our diagnostic tests. We get so captivated by the MRI. We have to have an MRI. If our patients don't have an MRI, then we don't really know what to do, and we've got to send them back to get an MRI. Well, sadly, some of the research suggests that approximately 30% of 30-year-olds have at least one asymptomatic bulging disc that presents on MRI. So 1 in 3 of your patients could present with an abnormal MRI that is completely asymptomatic. That's kind of a scary number. But if we're really going to address our patients, and we're going to take the MRI as a facet of the information, a little piece of the information that we tie in with their story, that we tie in with the signs that they present with, that we tie in with the pathology that we understand that they're going through, then it actually will round out the whole picture. But it's not the whole picture in itself. And so don't get caught up in that trap of needing that diagnostic test, that image, because that's what's going to prove it to me. The image should confirm what you've seen already from the patient. Theories. Let's consider theories for a moment. Theories of biomechanics. Proven, unproven, questioned. A lot of time with theories, when a theory is presented, it comes up because of something that somebody has seen clinically. And so they present it as a theory. And there's nothing wrong with presenting a theory. What becomes an issue is whenever we begin to take theories and we just accept them as fact and truth. And we act upon them as if they were truth. That then becomes a little bit problematic. A lot of times theories lack randomized controlled trials. They just haven't got that far yet. And so when we start to read some theories and we start to see in the literature some new approaches and new ideas and new ways of doing things, certainly we can try them, but we need to remember that it's just a theory. It's not an absolute. It's not a proven idea yet. There are some of the basic tenets that we as therapists hold on to that are only theories. The concave-convex rule that came about through Kaltenborn's work. It worked very well with wooden blocks, but it doesn't work so well with the human body. That was just a theory that was presented that has been accepted as absolute truth and absolute law, when sometimes it doesn't actually hold true. And so we need to be able to evaluate theories. When it comes to considering treatment of pain and stiffness, we've got to determine the kind of the disorder that's before us. What's the predominant aspect, or what's the predominant factor of this condition? Is it a pain-dominant condition? Is pain the thing that they complain of most? Is pain the thing that really drives them the most? Or is it stiffness? If it's a pain-dominant disorder, then we're going to address that in a completely different way than we address a stiffness-dominant disorder. Again, when it comes back to our grades, we're going to look at pain in terms of grades 1 and grade 2. We're going to look at stiffness in terms of grade 3 and grade 4. And so we've got to consider the type of the disorder, the nature of it. This all plays into our evaluation of our patient prior to us really getting into our treatment. When it comes to our evaluation, just to lead to that, we talk about this in much more detail in the subjective evaluation and the objective evaluation talks. But just a quick recap. We want to obtain a history. We want to interpret the data from that history. We want to then take that information to direct and to lead us in our objective examination. We want to review systems with special tests and measures. We want to check what we need to check. We want to work systematically. We don't just want to just randomly pick things. We want to work through our routine, work through our objective evaluation. When we get the information, we have been all the time taking the information and making it support or alter our hypothesis. We've been clinically reasoning our way through the case. We haven't just filled in a check sheet that at some point later we might sit down and actually try and figure out what's wrong. But all through our process, all through our evaluation, we are confirming, this is what I think it is. Yes, that fits, that ties in, yes, that all works. Or we're having to change our mind. Well, I was thinking it was this. I mean, everything so far has pointed to this. But then I did that test. And as I did that test, it was negative. I was expecting it to be positive. Because to fit my hypothesis, it should have been positive, but it wasn't positive. What could it be? How could this test change my hypothesis? What should it change it to? So all the time we're evaluating. We're reasoning our way through. We're not just blindly accepting the information without processing it. We're going to then take all that patient evaluation, all that information, and we're going to design a plan of care. After all, our patients have come there for treatment, not for assessment. We don't just want to assess them and now we know what's wrong with you, thank you very much and goodbye. No, we want to now take that information and we want to develop a plan of care. We want to establish goals of our treatment, and then we want to work towards achieving those goals. We're going to choose our assessment measures. We're going to determine our priorities. What do we want to do first? If it's a pain-dominant patient, then let's treat the pain. Let's not worry about teaching them a home exercise program just yet. Let's actually focus on the pain, because that is the thing that occupies their mind. That is the thing that is dictating what they can and cannot do. So let's treat the pain. Let's decrease it. We want to plan our approach, our whole treatment approach. We want to plan our strategy. We don't just want to set up, well, we're going to see you for the next 3 or 5 weeks or 12 weeks or whatever it is. We want to consider within their plan of care, but within our scope of practice as well, okay, what are we going to try and achieve? And when are we going to achieve it? Let's just jot down those things. Make those notes so that our patients know what our goals are. The patients know what we hope to achieve. And then as we work through this plan of care, then we'll see whether we're being effective or not. When we implement it, we want to educate. We want to educate the patient on what's going on with their back. We want to be able to get diagrams and charts and things like this and actually show people, okay, this is where your problem is. These are the joints. These are the discs. This is what you've done. This is why you've damaged it. Because as people understand what they've done, as they have the knowledge, then they have the power to then treat themselves. They have the power to avoid any further injury. And that's going to help our treatment. We want to assess, treat, reassess. Constantly assessing, treating, reassess. We're looking at the response to treatment. How did they respond? How did that feel? Was it an immediate response? Did the response take a day? So we treated them on Monday, and they report that on Tuesday, when they did their measure again, that it felt better. So we see them then on Wednesday. What's happened in that 24 hours? Assess, treat, reassess. We're going to determine the significance of the changes. So their pain went down. Is that a good thing? Is that a bad thing? A lot of times with our low back pain patients who have pain in their back, but then also pain radiating down the leg, the back pain may intensify, but the leg pain diminishes. Is that a good thing or a bad thing? We want to evaluate, we want to determine the significance of those changes. We want to repeat, modify, or discard our plan of care. Please do not just keep on doing the same thing again and again and again without any positive results. If it doesn't work, change it. If you're not seeing an effect, change it. Even if it's a negative effect, you should be seeing some sort of an effect. Don't just stick with a plan of care because that's what we set out at the start, but then nothing has actually changed. If you find yourself looking at your plan of care and realizing that you have had no beneficial or negative impact on this patient's condition at all, and yet you're still following this plan of care, then you have stopped reevaluating. You have stopped assessing, treating, reassessing. You're just stuck doing the same old, same old. Let's not do that to our patients. Let's reevaluate. Let's change and throw out our plans of care if they're not working. Let's start afresh. Reassess the situation, reassess the symptoms, and let's begin to treat our patients appropriately. And finally, we're going to evaluate. We're going to evaluate our goals. Are we achieving our goals? Are we reaching our goals? Is the patient achieving the goals? We want to confirm, and sometimes we need to modify the goals. Sometimes the goals are too lofty. Sometimes we need to bring them back down a little bit. Sometimes the goals are too easy. We need to increase them. But we need to evaluate, we need to confirm, we need to modify our goals. So when it comes to this whole idea of Maitland's philosophy, it's really a way of thinking where we look at our patient, and our patients are our greatest source of information for their condition, where we question them, where we assess them, where we evaluate the information that they give us through that, either a subjective evaluation or be it objective measures, and we take and we analyze that information. We create hypotheses as we go, and we rule in and we rule out. We affirm and we modify our hypothesis every step of the way. And when we come to the end, when we get our diagnosis and we make our decision as to what we consider this condition to be, we set a plan of care in place. And we begin that plan of care and we implement it, but then we modify it. And we change it as appropriate so that we're constantly evaluating the effectiveness of our treatment to ensure that our patients get the care that they need. When we come together in our lab class, we'll talk more about these concepts. We'll talk more about this philosophy. But we wanted you to have an understanding of where you're going. I want you to have an understanding of how we're going to start thinking. If you have any questions, please email them to me at jason.craig@marymount.edu, and I'll get back to you as soon as I can. But if I don't get back to you, or if it's only a couple of days before our practical session, then please bring your questions with you, and we'll address them during our lab day. Thank you.